Hey guys, so my topic is diabetic ketoacidosis. If you haven't watched Kelby's talk, I suggest you go watch her. She does diabetes mellitus, which is a great segue into diabetic ketoacidosis. So this is a complication of diabetes mellitus. Ketoacidosis is the breakdown of fatty tissue causing lactic acid that accumulates in your blood. Assessment-wise, you'll see your classic 3Ps, polyuria, polyphagia, polydipsia, nausea, vomiting, abdominal pain, and they'll have that hallmark sign of fruity scented breath. So someone comes in with those signs and symptoms, you think hyperglycemia, DKA, so you'll get a blood sugar on them. It should be above 250. You'll get a urine analysis as well. It should show high ketones in their urine. ABGs to see the metabolic acidosis, or if they have Kussmaul respirations. You want to be able to see their pH, their CO2, their gas exchanges. CBC, BNP, classic labs to see what their white blood cell count is. That can increase, infection can increase their blood sugar to go up, as well as a fluid and electrolyte issue. Most times these patients are hypokalemic. If you think about it, they have polydipsia, so they're drinking a lot, polyuria, they're peeing a lot, they'll have vomiting, so it throws everything off. Medication-wise, you give regular insulin IV, and you'll give normal saline to go with that. You give potassium, of course, if they're hypokalemic. That will be the first thing you do because you want to prevent cerebral edema when you give the other fluids. You'll know they're out of acidosis when their blood sugar is less than 200. So once their sugar is less than 200, you can go ahead and start and give subcutaneous insulin. You'll keep your IV insulin running for 1 to 2 hours while you do that because of the different half-lives. We know that IV insulin is going to work a lot faster than subcutaneous. You also go ahead and start administering D5 at that time as a preventative for hypoglycemia. Yeah, we're dropping their sugar, but you don't want to drop it too low to where it's below 70 and it's causing a whole nother issue. Other interventions we want to do that we should know by now, these patients are critical patients. They're typically in an ICU, so they're going to have close monitoring. So they should be on tele, have a Foley in, because if we're going to give them potassium, we need to make sure they can excrete that potassium. They're going to do your blood sugar check. So depending on your hospital you work at, they'll have a policy and an algorithm that correlates with the insulin titration. If their sugar is above 600, you'll set it at so many units and check their sugar every so often. If it's at 300, you'll set the pump to this many units and check their sugar every 30 minutes or whatever. Education, I think, is the main prevention for DKA. These patients need to be educated on how to monitor their sugar at home, when to monitor their sugar, monitor their ketones when they're hyperglycemic, because that's a good indicator of DKA when they have ketones in their urine, especially when they're ill or they have infection or they're stressed. They need to know how to administer their insulin. If they're not going to eat right and not exercise, they at least need to be taking some preventative and getting some insulin to help combat that hyperglycemia. Exercise and nutrition, those are really good alternatives that involve no pharmacologic intervention at all. And then infection prevention. Like I said earlier, infection can increase their blood sugar. So the classic stuff that we think is very basic to us, maybe our patients need a refresher on. So checking their feet every day, cutting their toenails a certain way. They have that neuropathy, so you want to have them check their backwater with their hand instead of their feet, stuff like that. That's pretty much it, a basic rundown. If y'all have any questions, let me know. You can just put it on Blackboard. Thanks.